Hello, and welcome to the No Bad Questions podcast, where I try to learn in a conversational manner by sitting down with people who have interesting careers, important lessons to tell, or inspiring stories. I hope that you learn something too. If you want to support the podcast, please follow or subscribe on your platform of choice. You can also like or comment to boost the algorithms or share out to your network to make sure it gets more views. But ultimately, and what I hope you choose to do, is listen to the very end. With that, we'll start today's podcast. Hello, and welcome to this week's episode of the No Bad Questions podcast. I am very pleased and excited to be joined this week by Dr. Robert Wagner. Dr. Wagner got his MD from Albany Medical College, and he has worked in both corporate-owned hospitals, community hospitals, and for vendors and consulting organizations within the healthcare space. Today, he is a working emergency department physician in Georgia. He is the father of one, and I would like to say personally, a good colleague and a good man. So thank you, Dr. Wagner, for being here with me.
My pleasure, David. Glad to be here today.
So when I reached out to you to come on, I think we'd shared, either you had shared or we'd both enjoyed an article online about sort of the state of the emergency department today. How much of care Americans are getting in the emergency department. I think the article was almost 50% comes through the emergency department. You're there, you're living it. What is the state of the emergency department today?
Yeah, David, I've been in the ER. I've been a practicing ER doc for about 30 years now. So I'm considered an old timer in most circles. I'm going to be 60. And so working full-time ER at 60 is different from working full-time ER when I was 30. But things have really drastically changed in so many ways. I mean, patients are still patients, and people come because they're sick or they feel bad or they have a perceived issue. And then there's the traumas and the gunshot wounds and all those things, and those are still there. Pre-pandemic was pretty much the way I was used to it. A lot of patients come into the ER, pretty stable. We knew sort of had a feel for what were our busy days and what were our slow days, and what the disease states would be. It's flu season, it's CHF time, it's full moon Saturday night. We had a feel for it. And then there was COVID, and everything changed. At first it was don't come to the ER if you're sick at all. And so the ER suddenly emptied out, and then when COVID wave came, you got extremely busy and you were holding patients everywhere, and there were patients everywhere. And that was a very difficult time. How do we manage it? And how do we do things? And post-COVID, things have really, really changed. We're seeing higher volumes than we've ever seen before. And it's not just my ER, it's the ER in general across the country. I talk to a lot of friends and stay up on the literature. So our volumes are way higher than I've ever been. People are seeking a lot of their care in the emergency department. They're finding difficulty accessing a primary care physician or even accessing an urgent care. Because one, it costs money to go to an urgent care. They have to pay up front. And two, the accessibility for an urgent or emergent problem is much more difficult. So they come to the ER. We're also seeing a significantly more complicated population. So COVID took out a lot of older folks who had comorbidities. So a lot of older folks with comorbidities got very sick with COVID and died, frankly. But then there was a significant number of those who survived, stayed inside, that have multiple comorbidities, that we got really good at taking care of them, and now we have a much older population that are much sicker. And so I'm seeing more and more patients in their 80s and 90s with multiple illnesses and comorbidities that are coming to the ER. Just a lot more. A lot more sick cardiac patients, a lot more cancer patients that have survived long terms, a lot more cardiac patients that have had left ventricular assist devices or are having other comorbidities that are showing up in the ER. And so the degree of complexity has increased dramatically as well. And so I would say across the country, the volumes are up 20 and 30%, and the complexity is logarithmically higher than it was before. So it's been interesting.
There's a ton of stuff in there to break down. The first thing I want to do is break down a language piece for folks who listen who may not be in healthcare and may not feel like Googling it. Comorbidities.
Right.
What does that mean? I mean, I know what it means from a billing and coding perspective, but to a doctor, what does comorbidities mean to you?
So if somebody comes in, let's just keep it simple. Somebody comes in with chest pain. And let's say it's a 50-year-old gentleman who comes in with chest pain. And the chest pain has some typical features that sound like cardiac chest pain and some atypical features. So what would be a comorbidity? Diabetes would be a comorbidity. Hypertension would be a comorbidity. Okay. Hyperlipidemia would be a comorbidity. Smoking would be a comorbidity. Strong family history of cardiac disease in that age group would be a comorbidity. These are things in your healthcare history or disease states that you currently have that increase your risk for adverse outcomes associated with a particular disease state.
Okay, I appreciate that. And does that, for those of us who only play physicians on TV, does that change how you care for people in a dramatic way? I mean, I'm sure it changes how you care for people, but I mean, is it a dramatic change, or are the changes pretty small and subtle when you have a 50-year-old male with diabetes who is there for chest pain, or has their dad died at 52 of a heart attack? Is that a dramatic shift in how you care for somebody?
No, I think I've always cared for that patient that way. But that patient will get admitted versus a 50-year-old patient without multiple comorbidities who may have chest pain. We can score patients. Okay. So there's a lot of evidence-based medicine out there now, and there are a lot of support for that. There's applications. There's also companies that work with you to ascertain patients' comorbidities and define and risk stratify them. And so we can risk stratify those kind of patients to whether they stay or they go. And it's become a little bit easier to do with applications and data. But let's say, we are seeing patients who live longer with multiple comorbidities. So a 90-year-old patient who comes in and I just feel weak, right, who has a history of diabetes and hypertension. It could be anything. A 90-year-old young lady who comes in with just weakness with fairly normal vital signs, or maybe even a low-grade temp, can have anything from a heart attack to a urinary tract infection to pneumonia to an abdominal catastrophe. So those comorbidities, those risk factors, have really increased the complexity of the patients that we see today. So what that does is it increases the cost of the workup. So I'm doing a lot more to patients to try to determine whether they do or do not have any illness that requires treatment or hospitalization. It increases their length of stay in the ED, so it backs up the ED a little more. I admit a lot more of those patients for longer observation or longer workup, so it increases the number of patients in the hospital. And I'm sure you're aware that there's a lot of holding going on in the ED because there's not a lot of beds in the hospital, and there's a nursing shortage on top of that. So all those things combined have resulted in this huge backup in the ED, not just mine, but we're holding a lot of patients. And there's a new article that just came out in JAMA, and we can talk about that, about ED holds and left without being seen.
Yeah, and I've heard about that through organizations that I either work for or talk to about holding patients or boarding or, whatever the terminology that folks choose to use for their organization. But okay, I appreciate you sort of doing the remedial component for folks who might be listening there. And one of the other elements then in the first segment, because you opened a lot of doors in the second segment of what you just talked about as well. But in the first segment, you also talked about then, I think, the stark morbid reality that I don't think society has truly come to grips with yet, which is the death or acceleration of death. Maybe somebody was sick already with cancer, but they would have lived 12 months and they died in 1 month from COVID. COVID, regardless of anybody's political feelings about it, COVID killed a lot of people. And as you said, many or most of those folks were an older population. But our society is skewing older. We're an aging society. Do you think that some of what you're seeing, is this just in your opinion, is this a blip? That we're going to get past it? Because I hear a lot of people like, oh, we got to get past this. We got to get past this. And I'm like, well, okay, maybe. But if society is skewing older and older folks often have more of those comorbidities, is this a thing that we're going to just get past? Or is this reality for the next 10, 15, 20 years as society increases in age in America?
David, I think you hit on a great point. I think things have changed dramatically. I remember sitting in front of the TV and on 9/11 with my wife. I had worked a night shift and she had woken me up, and we watched that second plane crash, and we both looked at each other and said, the world's about to change dramatically. And it did. It changed so many things. And I believe what we as a society, not just our country, but the whole world, went through with COVID has changed the way we live our lives and look at things. One, we got locked down for almost 2 years, pretty much, right? At least a year, but probably closer to 2 years in general. A significant number of folks lost loved ones, young or old, but a lot of comorbidities. A lot of people got very, very sick. And then there are people that have long COVID and they're still sick and they're struggling with mental issues and lung issues. And I see a lot of that as well. And then the whole society is looking at things differently. We have telehealth. We have Zoom. Was this here really before? Right. And we have all kinds of accelerated technology and accelerated healthcare. I was listening to the news today and listening to one of the stations I listen to, and there was a guy talking about what should I invest in? And he really wants to invest in healthcare. Even though our margins are shrinking and things are getting tighter, he says technology and what we've been able to do during COVID is going to change the way we take care of folks going forward. And I do believe that things are going to change going forward. Right now, I think the world has changed. The type of patients we're taking care of is changing. The technology we have to support the care is changing. The tools we have to care for patients is changing. It's accelerating. I think we're going to get better at managing what we have. I don't think it'll ever go back to the way it was. So I think patients in our country, there's a demand for gratification, instant gratification in so many things. And in healthcare, people and patients expect to be well. And even a minor illness will drive patients to the ER now. Cough, cold, congestion, hangnail, right? A lot of patients are coming in because they don't want to feel sick. And so we're seeing an explosion across the continuum of healthcare, which is backing things up in the ER, which is causing, however you want to say it, holds back up. And whether that's nursing shortage, bed shortage, or just flow problems. And that's a whole other podcast, David. And we can get my wife on that one, as she's a nurse director of an ER. But, you're holding, I'll go into the ER, and we have 19 beds, and there'll be 12 holds in the morning. So we only have 7 beds to work with, but we're short 3 nurses. And so we're working out of one bed first thing in the morning, trying to create turnover. And that's fine, and that's the way it is. But I think we're going to learn. We're very adaptable. Not just healthcare in the industry of healthcare, but people, right? I mean, we are very adaptable at what we're doing. We're going to adapt to what we have. Technology is going to increase our ability to leverage AI, and bot technology is going to increase our ability to manage flow, and people is going to increase. And we'll learn how to do this. I believe that. And we're learning now. I think the people who go into healthcare, at least at the point of care, are passionate. And I think you have to be passionate. People will ask me, should I go into healthcare? Should I be a doctor or a nurse? I said, well, what do you love? What do you love to do? Right? And so if people find what they love to do, if it's a little difficult or a little hard or a little busy, it's okay. So to answer your question at the end of the day, yes, I think things are different. Yes, I think they'll continue to be different, and they'll continue to change. And yes, we'll continue to adapt, both personally, professionally, technologically, organizationally, and all those things will continue to get better. I think we deliver great healthcare in this country, and we'll continue to do that.
I appreciate your insight on that. And one of the things I sort of felt there as you were going through that is I feel an optimism coming from you but I know so many physicians, and not just physicians, nurses and other caregivers, and maybe even people outside of the healthcare industry, although I know that burnout was originally coined as a term related to physicians, but are feeling burnt out. And I've started to see other folks say that it's more than burnout, or use this phrase instead of that. But ultimately, it's people just aren't feeling it in their job anymore. And yet I was picking up on some optimism from you. So can you talk about that sort of juxtaposition of the optimism versus, I'm sure you have felt, or you have peers who are burnout. I mean, how do those two balance? Does it depend on the day? Like when do we catch Dr. Wagner? Is he feeling good or not? I mean, how does that work?
Both some of the former and some of the latter, David. I think we all go through our ups and downs in healthcare. I went into medicine because I love taking care of patients. And I'm in the emergency room because I love that type of episodic, high acuity, high volume, high chaos type environment works for me. But yeah, I think you and I were talking before the podcast. I just came back from a vacation. And on that vacation, I had time to reflect on, did I really love what I was doing? And I got back to the why. And I'm sure you're a Simon Sinek fan, and it's all about the why. And so the why is I went into healthcare because I love to take care of patients. I went into being a physician because I'm fascinated by the brain. I'm fascinated by the body. I'm fascinated by anatomy and physiology and evolution and all those things. And then more and more patients fascinate me. Sometimes it's, why are you here? Right? Why are you in my emergency room this morning? Right? To, oh my gosh, I feel horrible for you. How can I help you? Right? And I think as a physician, I've become more and more convinced that when I'm in the emergency room with, 19 rooms, 40 patients, 20 patients still trying to get back, 2 ambulances on the way, and 12 nurses who are pulling their hair out, if I stay positive and I stay on point and I'll try to sort of you can't cheer, but if I stay positive and I keep focused, that the whole team will follow that, because that seems to be what happens. But if I come in and I'm throwing things and I'm yelling and I'm frustrated, then the whole ER falls apart. And it's not easy to do. I've gone through periods of burnout. Take a vacation, pray a little bit, talk to other people. And I've been to the point where I've said, do I need to stop now because I'm hating going to work? I'm sure we all have. But when I stop, take a day or two off and look at why I do what I do, right, then I'm fresh and ready to go again. Because, David, as you know, I've worked in ER, but I've also worked in serious revenue cycle positions over the years, right? And I find my purpose in patient care.
And that's great. And I think the why, the message of, I think that's one of the wonderful benefits of being in a caregiving profession is to me, because I'm not in one. So I'm guessing my wife is, I'm not, you are. And many people I know, because I work in healthcare, are. I feel like the why might be clearer for a physician. You know why you got into medicine, and you committed years and years and years to the education. And somebody in a different profession or different industry may have more of a challenge with their why if they're feeling burnout in their career. But yours, I think, is a great story, and in particular the thing about that and allowing that to drive you. That said, I know there's some docs who maybe they can't get to where, they're figuring that out, or they're balancing it, or they're keeping the why forefront of mind enough to overcome the burnout. And I've heard from some of them, and some of them, maybe are considering a more administrative track. And as you mentioned, you've done some more administrative type work, and now you're back into, just being boots on the ground, taking care of patients. Mm-hmm. What would you say to anybody out there? And this is, I guess, a pretty niche question for listeners. So everybody skip ahead 3 minutes or whatever if you're not a physician. But if you're a physician who's burnt out, or a nurse or whatever who's burnt out on the care delivery side, and you're thinking about, maybe should I go a management or administrative side? What would you say to somebody like that?
So I think it's not only a healthcare question. So you don't have to tune out. I think it's an anything question. I'll give you an example. So I worked for a couple of different revenue cycle companies over the years. And the passion was, I think by doing what I'm doing here, I can help generate more revenue so that we can pour more money back into the organization, get more MRIs, more tools for the caregivers to deliver care, another nurse, a tech, whatever we need. And I felt like that was a really passionate, and that was the way I was early in my administrative career. But as I've moved along, that passion for me kind of dissipated a little bit. And I was working at the last company I was working at, and we were at a big meeting. And the passion of the people who were doing the revenue cycle was they were extremely passionate about what they do. Have you ever sat down with a CDI nurse who's doing CDI? They're so passionate about documentation. A case manager is so passionate about a good case manager, right? A great revenue cycle leader is just passionate about finding those pennies that are in the couch. It's unbelievable. And the passion is just incredible. And I remember sitting in that meeting going, I don't have that passion. I like this. It's fun. I enjoy it. But where do I find that passion? And I find that passion in direct care giving to patients. And so if you're out there doing any job and you feel empty or lost or you're just plugging away, what's your passion? And I talked to my son about this. What are you passionate about? Find that and try to do that. I feel blessed, David, that I am in a career where I just freaking love it. There are days that are horrible. I'll go in and I'll be at work and I'll have to step back and call my wife and say, I'm just hating being here, right? But I have to sort of, she puts it in perspective, right? And it gives me a chance to talk to somebody to put in perspective. I've been married 30 years. She's my best friend. She knows everything about me, and she's an ER nurse, right? So she understands. But I think in anything, finding that target, that center of that target, and building out from there, if you can, is ultimate. If you can't, find something that you can live with day to day, and then go home and play with your kid and your family and do fun things, and that's okay too.
I like that, and I appreciate that you tried to make sure we went beyond healthcare, and I then, I guess, doubly or triply appreciate that last part at the end, because I think that a lot of folks give career advice and, we got to find your passion, which is good advice, except when maybe what you're passionate about can't, put a roof over your head and food in your mouth or whatever, in which case I think the last part of what you said there is critical. Yeah. Then find something you can sort of deal with, live with, and find the passion elsewhere, your family, a hobby or whatever, and put in the work, go do a good job, but then work's work, and come home and find it elsewhere. I think where I get, not anxious, that's not the right word, but where I get downtrodden is when I get moments of, whether it's reading the news or whatever, and about widespread, mental health anxiety in our society, about like imagining how many people are out there who don't have any passion, whether it's at work or at home, like a purposeless life. And I feel for that. That's got to be terrible. And I don't know how those folks, how to help them. I don't know that I can help them, somebody who's not finding purpose or passion in daily life. But that kind of allows me to segue to, I've heard and read that a lot of what's coming into ERs today, you mentioned the increasing complexity and increasing age of patients, but I've been hearing and reading a lot about mental health and how much mental health is starting to see its way into emergency rooms across the country, sometimes clogging those up because those are the folks waiting on a bed because there's 7 beds in the whole state or whatever for an inpatient psychiatric patient. Is that true? Are you seeing that? And if it is true, what the heck can be done about it?
So going back to the last discussion we were having about passion, I think, my son's sort of a different generation. He's 24 years old. And I think, we in my generation, we live to work. That's kind of the way it was. That's the way I was trained. Mm-hmm. But these guys work to live. They work so they can generate enough revenue to live the life that they want. Travel, games, sports, and that's a little bit different perspective. And that's okay, too, as long as what you're doing, is okay with you to generate the revenue you need to do the things you want to do. Play guitar, travel, do those things. The other part of that, just to add one more piece to that, is my wife and I talk a lot about happiness versus joy. Completely different things, right? And I think I don't necessarily have to be happy every day I go to work, but I do find joy in what I do, right? And that's a completely different thing. I have a connection with, a God that I think is crazy about me and loves me, and however you want to sort of look at that. I have a connection with family that are crazy about me and love me, and I'm comfortable in my shoes when I get up in the morning and go to work. And I think that for me is joy. I have people that are around me that care about me and love me, and I find joy in what I do. I'm not always happy, and every day, some days are just horrible. But at the end of the day, I have joy. From a mental health standpoint, so yes, we're seeing a ton more psychiatric patients in the ED. Whether it's straight up psychiatric schizophrenic patients, or they are dual diagnosis with drugs. And so I'm seeing a ton of patients who have nowhere else to go, and there's a lot of recidivism. So patients will show up, they'll be schizophrenic, they'll be brought in by police, they're wandering around town, or they were violent, and we'll have to sedate them to calm them down if we need to, get them on some medications, get a psychiatric support, which I am lucky enough to have in my hospital. Not everyone does. And then find them a place to go. And often they're in the ER a week or 10 days in a little room with a padded bed with no windows, no TV. And that would drive anybody insane. Trying to give them meds and manage their comorbidities. So let's say we have an older population of psychiatric patients now, and they also have comorbidities like diabetes and hypertension. So you're trying to manage a acutely psychotic schizophrenic patient who also has diabetes and hypertension who won't take their meds and are violent. And those are very difficult. And say you have 4 of those, right? And so those are, and placing them has become very, very difficult. And so we've used, and we're lucky enough to have telepsychiatry support, which has been great. They help us manage meds and manage management and decide how we manage those patients. And it's been a blessing for us. But the volume of that has increased. And it's increased the burden on the nurses, too. Because, one, you have to have security to manage those patients. There's only a very special way you can keep them in the rooms. There has to be line of sight. The rooms have to be set up a certain way. The doors have to be set up a certain way. Everything has to be set up a certain way. There's a lot of rules and regulations about how to manage the patients so that they don't hurt themselves, right? And it's very important. And I agree. But I treat mental health as serious as I treat a heart attack. We've also seen a lot of younger patients. So pediatric age from 6 to 18 with suicidal and aggressive behavior that we've been seeing in the emergency room, and having to manage them and manage all the associated stuff with their parents and the patients and find a place for them as well, which has become difficult. So that's been a really difficult problem, David. I don't know if there really is a solution right now. I think we're learning better how to care for them in the ER as those volumes increase. We're still, as we talked about earlier, trying to figure it out and getting better at it every day. Again, for my team and where I am now, I found the support of telepsychiatrists who understand that disease state the next level than me. Like I know when to diagnose an appendix, but I can't take it out. I can diagnose, by acute bipolar or, acute schizophrenia or, any of these disorders. And I know some of the meds, but it's really nice to have support from a trained psychiatrist. And then we also have developed some community support. So psychiatric support and then community support. What do you have in your local community to help manage these patients? How are we transporting them? What places do we have for them? What is your state doing to support them? And so we have a lot of that as well. So difficult problem. I think it's going to continue to grow and get worse. I think sometimes it's also managing that patient. Is it psychiatric or do they go to jail? When the schizophrenic patient beats somebody up and punches a police officer and they're acutely schizophrenic, should they bring an acutely psychotic patient who's violent to the emergency room? Where's that line? And we find that really difficult. We've had also great law enforcement support where I am versus, let's say, where I have some other friends where they just drop them and go. And so they leave this acutely psychotic patient without any police support until we can get them settled down. It's nice to have, law enforcement support while you're getting the patient settled down to a point where they're more manageable and they're somewhat medicated. My town where I'm working, I'm lucky to have that. I have friends who don't have that kind of support. So it's all working within your community. I think what I'm trying to say, David, it's a big team effort between different medicine, so ER doctors, psychiatry, social services, law enforcement, nursing. And I think you have to sort of have that team approach to it because it's not going away and it's only getting worse.
Where do you think, as I understand it, a lot of the inpatient, overnight, longer term psychiatric facilities were defunded, decades ago. And yet you're talking about an increase in this stuff recently, where particularly the schizophrenia. Like, I know you're not an epidemiologist, but where do you think this is coming from?
Right. So we talked earlier about we take better care of patients, right? We're able to take better care of patients with comorbidities and other illnesses. We're able to prevent these patients from hurting themselves. And also I think law enforcement has become more sensitive to, are they really psychotic or are they just violent people? You know what I mean? Is it psychiatric or is it just, a violent human being? And so they're more and more recognizing that the patient has a treatable psychiatric illness and they're bringing them to the ER more and more. So we're seeing a pile more because it's recognizable and more recognizable. And I think that's great. We have found that patients will sit in our ER a week and we'll get them medicated and get them settled down. And we do have some outpatient services available for uninsured patients, but not a whole lot of inpatients for uninsured patients. For insured patients, there's still facilities that will take. For kids, there's still facilities that would take. But for the insured population, much easier than the uninsured population. The problem with some of these folks is that they would be Medicaid eligible, but they don't sit around long enough to do the paperwork or follow through or do all the things they need to do to get them covered. So there's a struggle there as well. Also, they're a transient population, right? So we just had a lady who, I'm not really sure where she's from, but she's never been in our town before. She's been sleeping in doorways, harassing customers, and we're not really sure where she's from. But the story is she told me that she's from Buffalo and she's been working her way south through towns, and she's an artist. She told the police officer she works for the Kremlin and she's on a mission to determine whether there's infiltration in our country. She has 4 different names. One's Hindu, one's American, one's British, and she has different accents. We don't know where she's from. She has no ID. She just showed up in our town. So she's been in our ER about 5 days because we can't identify who she is or where she's from or what her real name is or does she have insurance or not. So we do have some resources. So we have a support team locally that gets her on a list, and we sort of work our way to find a place for her. And we get our psychiatrists here and see if we can get her to start taking some meds. All right. So we work our way through. And the good thing is, as an ER doc, I have the opportunity to examine her and talk to her and clear her medically. So make sure there's no organic problem causing her acute psychiatric illness.
All right. So you were talking, I don't want to make you restate yourself there when we had a bit of a bandwidth challenge, but you were talking about, getting people the beds they need, the law enforcement support, trying to figure out if these are just criminal acts or if they're, I shouldn't say just criminal acts, if it's a criminal act where they need to go be sort of medically stabilized or they need to go to jail first. And what I have to wonder in all of that, and maybe it's a bigger question than you or I could answer, but how much of this comes from maybe societal, environmental elements? And what do I mean by that? What I mean is there are, I think people call it the social determinants of health, right? Stressful home environment, on social media all day. Maybe we're not eating well. Maybe taking so many meds, the meds are conflicting with each other. Maybe it's, living longer, so then we get dementia, so then we can't, control our behavior well or something like that. How much of the mental health challenges are, I might not use the right words here, but do you think are driven by essentially psychosocial comorbidities, if you will?
Okay. Yeah. Social determinants of health is always an interesting word and an interesting sort of phraseology. I'm not a big fan of that particular phraseology, and I think there are some clinical folks that feel the same way. So we talked earlier about the world's changed post-COVID, right? And I think, being locked up for, or, locked down for 2 years has changed the way people do things. There's people who are out there who are incredibly manic, right? They're using their credit cards, spending all their dough, traveling everywhere, buying new cars. Well, we know that's probably not the right thing to do, right? But they've been locked up for a couple of years, and they're just doing that. There's folks that have hunkered down and are saving every dime, and they're depressed and sad, and they're the other way, right? So I think that we're seeing a lot of dysthymia, right? People way up here and people way down here. But I think overall, some of the things you described, the current society we live in, the ability to never leave your home and do everything online, right? The impact of constantly being barraged on the internet, right? The impact of pornography, which is, available to kids and adults now on a sort of incredibly basis that, was never there when we were kids. The amount of information that comes at you. I remember, leaving home and my mom couldn't reach me, and now we're constantly in touch with everybody all the time, saying things we probably would never say to somebody's face, but can say if I text them or put it on Facebook or Twitter or TikTok, God forbid, right? I mean, I can't believe some of the stuff that I'm not on, by the way. So I think that there's a lot of that contributes to the mental health issues we're seeing today. But again, I think the recognition of it as well, right? We're much more recognizable of it. We're much more accepting of that this is an actual diagnosis now. And I think we're much more sensitive to it, both as a society and a profession, to say mental health is just as serious a problem for me as somebody who comes in with a heart attack. And I get these folks that come in, they're depressed and sad, and their mom brings them in or their cousin brings them in, and they don't want to talk. And I think the discussion I have with them is, listen, I'm glad you're here. I'm glad you came today. I'm really proud of you for bringing this problem to me, because I take this as seriously as somebody who comes in with chest pain and I think they could be having a heart attack. So let's treat you that way. And I think patients appreciate that. And I think, the recognition of it across the board, both from us as clinicians, nurses, social workers, and law enforcement, and families, and sort of, culture in general is important. Managing it and how we're going to manage it long term as a healthcare industry is I think TBD, right?
Right. And in the short term, we have a shortage of physicians and nurses and respiratory therapists and everybody who takes care of patients. And as we were talking about earlier, I'm not sure how much of a short-term blip this is versus a long-term, this is the way it is. And in particular, the more credentialed a job, the longer that gap is probably going to take to close. So a nurse, takes a couple years worth of training and education. A physician takes a decade. So what if anything, can we do to try to close the shortage, because I mean, you mentioned, hey, I take mental health as seriously as a heart attack. I do these, try to take the good care. But the more and more you get time pressured because there's not enough people around to do the work, I'm sure the more pressure there is, not that you wouldn't, but the more pressure there is to find a shortcut, find a loophole, whatever. And knowing you, I don't believe that's something you do, but I'm sure there's folks who just, hey, let me just get this patient out of here, right? Let's just get him out of here. And I don't want that contributed to by there not being enough human beings to do the work. So how do we close that gap, considering it may take years to train? And that's if people were even going into the professions.
Yeah. Yeah, David, I'm not altruistic. I do find sometimes the lowest common denominator that does no harm, right? And I think sometimes you have to do what you need to do inside of the system that you're given. But again, above all, first, do no harm, right? And I think that's important.
Right.
We truly have a shortage of nurses. We close beds in hospitals all over the country now because we don't have enough nurses. And those patients who come to the ER end up boarding or staying or becoming inpatients in the ED, which again, puts added stress on the nurses that are working in the ED and the doctors that are working in the ED and the techs and the respiratory therapists. And I just saw an article where physicians are leaving the practice at, I think, there were two different articles. One said 115,000 physicians left healthcare. The other one said 300,000 in the last year, since 2021. And that's pretty incredible that physicians are leaving.
Wow.
They're getting burnt out. And burnout means a lot of different things, but it's become more and more difficult to practice on multiple levels. Not just the patient volumes, but the demands of the machine, right? The demands to see patients faster and see more patients and turn them over and document properly and use the EMR and finish your charts and see the patients in a certain time frame and achieve these quality measures and document well and be nice to everybody and your satisfaction scores have to go. It's just so many pieces to it. It becomes overwhelming and you end up with this, I just want to take care of patients, right? It becomes difficult. I think, again, we're evolving. I think that, as healthcare providers, physicians, nurse practitioners, physician assistants, nurses, respiratory therapists, phlebotomists, we're short phlebotomists everywhere, transporters, people that clean the floors and clean the beds, all those people are stressed out. I think we're going to find how we're going to manage in this current society where, the pendulum, and you've worked in healthcare long enough, David, on the revenue cycle side, that you see that the pendulum swings. It never stops where it is calm and comfortable, does it? It has to go all the way to one side, and stuff has to go to heck before we can start to swing it back. And I think we're seeing a lot of pressure and a lot of stress right now. And I think it'll begin to swing back, and the people that love healthcare will stay in it. And the next generation of healthcare workers, physicians and nurse practitioners and PAs will start to come up and they'll see newer and different ways. They'll get used to managing things in a different way, right? You can get used to anything. And I think the way hospitals are managed by both private and public companies will change as well as they continue to try new things to make their margins, which, no margin, no mission, right, David? So I think, we're looking at different ways, right? There are more nurse practitioners and more PAs and less physicians. And we're looking at ways to manage more quickly. So we're getting better technology, right? Where does AI fit into all this? I don't even know. I don't know. I'm really into AI. I really love it. I took a course at one of the major places, major universities, and have a certificate to say I am certified in AI for healthcare. But I still don't see its real application yet other than maybe NLP. So I do think we're evolving, David. I don't think there's a pat answer for that other than we should continue to evolve. I'm trying to avoid the sun. I'm sorry. We should continue to evolve and see where we go and keep a positive attitude and find the joy in what we do day to day. I think, I think there are some really smart people and some real good leadership working towards it. And you know what? We had talked earlier about How do you make that transition if you're no longer finding your passion in patient care, or it's just become too much for you? Is your passion making things better for Medicaid patients? Is your passion, helping work within the hospital? And I'm going to use my wife as an example. She, she's a nurse, but in her second career, she wants to be an administrator. And the reason she wants to be an administrator is because she wants to make things better at the level of the team she works with at the hospital, right? So she wants to make things better for her nurses and her transporters and the people that work in the ER with her. So she's a director of a 65,000 volume ER in a for-profit system. But she's working really hard to create a better culture that supports the quadruple aim, right? Where we get the providers are the fourth aim, and provider satisfaction and good outcomes. And her goal is to move not from nursing leadership, but to hospital leadership, where she can help drive that across the system, while at the same time understanding we have metrics and goals and things we have to do in order to pay for everything we do. So it's that finding that balance of where you are in the hierarchy. Because she was a neurosurgery ICU nurse, and now she's driving to be, something more in her mind. Or something different, maybe, David, not more.
Yeah. And I think the drive to make it better is something that we need, and that we have to do it fast. Not just our industry, not just healthcare. The world is changing, and it's changing fast. The pace of technological change. I mean, you mentioned AI, and I think there are a few use cases in healthcare, and I'm trying to look for some guests right now to come and speak about that. But so if you're listening, get a hold of me. But I think there are some use cases, and I think there's also some vaporware. Mm-hmm. But the point is that stuff is changing fast. And you've actually mentioned technology a few times, either the electronic medical record or EMR, and having to use that, or tools you mentioned to sort of look at how sick the patient is, and should they stay at the hospital, should they go home? And do you think, and I know there's some docs, maybe there's not very many still practicing anymore, who wish we could just go back to a pen and paper and that was the chart, and there's others who love technology. Where do you stand? Do you feel like, I feel like I know because you've talked about it a few times, but is all this tech making the actual delivery of care better, or is it in the way?
Yes, I used to think I knew. Right? I used to say, I'd love to go back to the old way. I just scribble on a page and stuff gets done. But then we have a downtime, right? So the EMR goes down, mm-hmm. and it is chaos. It turns into chaos. And not just because we don't know how to sort of move things through the hospital, but how do I get my labs back? How do I get anything in the fashion? I'm used to things turning over, right? Boom, boom, boom. I do things and it gets done, and I have my result. I can look at it on the computer, and I have my X-ray results and my lab results fairly quickly, and they come up online. And when we have a downtime, that doesn't happen. And I used to go, man, I hate the EMR. It's just a piece of machinery for the man to generate revenue. And at the end of the day, I think I think it's more than that. And I didn't always think that way. I'm not a fan of the way it's built now, but I do believe that it was originally built to collect data to generate revenue, whether it was clinical data or non-clinical data. But I think it's evolving. And I think that the leaders that manage these are jumping more and more on board. The guy, the CEO of Cerner is a physician. Right? The new CEO of Cerner is a physician. And he's a great guy, and he knows what he's doing. And he's all tied in with Oracle now, right? Because Cerner was bought by Oracle. And they're working really hard to make this thing more clinically friendly, more supportive of the clinician. I was struggling yesterday, for example, because I was just, it wasn't working right. And I just couldn't get the keyboard to work right. I couldn't get the EMR to work right. And I was just getting through it, right? And just kind of trying to keep a smile on my face. Well, it just so happened some of the folks who do that at my facility were wandering by. They cleaned up my computer. They cleaned up my keyboard, and there were a bunch of order sets that I was struggling with. And we went through them just in 10 minutes because that's all I really had. But an hour later, I had a new keyboard, my computer was working better, and some of the order sets have been cleaned up, right? To make it more facile for me, less clicks, easier. I think the younger generation will find the EMR and the electronic medical record more facile and more effective in their workflows because it's always been disruptive to workflow. I think as we move forward, I'm very comfortable with it. I think introducing things, and so in my EMR now, I have, direct access to the database, that the drug use database. So I can just click a button and see if this patient's had narcotics in the last year. I can click on it and get my call schedule. I can click on it and check some evidence-based data, right? So there's a number of things I can do now in the EMR that I couldn't do 2 or 3 years ago. I think, as we get better at evidence-based care and using AI to support us, I think it's going to continue to get better. There's a guy named Eric Topol, and I don't know if you've read any of his work. Eric Topol's a really brilliant guy at Scripps, I think, who writes a lot about technology in healthcare. And his latest book talks about where AI is going to put us. And his hypothesis is that it's going to create more of a level playing field with doctors and nurse practitioners and PAs around our access to evidence, right? Is that even though I may be higher IQ and I may know more about the pathophysiology of disease and what medicines to give, AI is going to level that out. What it's not going to be able to do is level out compassion and empathy and then gestalt, right? I know that patient's sick, and there's something more than the data can tell me about that patient. So,
right.
But I think as it levels us out a little bit, it'll allow us a little more. His theory is it's going to allow us a little more time to think. It's going to allow us a little more time to be compassionate. It's going to allow us a little more time to touch the patient, right? It's going to allow us a little more time to be doctors again, where now sometimes I spend my 60% of my day, pounding the keyboard and clicking the mouse. So I thought that was an interesting way to think about it.
I hope that that's correct. That's the way I've been trying to think about the potential outcomes of technology, not just in healthcare, but in many professions, is I hope that the AI can essentially remove the drudgery from some types of work. And that you can have whole podcasts and conversations and books about that and what that would look like and what that would look like in any given profession. You could probably have a book on a single job in a single industry on what a future state AI empowered job would look like. And so it's way more than we could get into here, but I like to think that the empathy element is something it frees up. And the other thing I like to think that it might free up is the time for a physician to really engage, because I believe from talking with you, from talking with some of my guests in earlier conversations, particularly episode 5 about healthcare quality, from an upcoming episode, at least upcoming as of this recording, with another physician about some of the telehealth and how it allowed doctors to see into people's homes, because we haven't done house calls for 70 years, and you can start to see some of the other elements in their environment that were afflicting them. I hope that it adds time so that those of you with that brain on your shoulders and with that decade plus of training can bring it fully to bear.
Yeah, it's a great way to think. And again, I'm not fully on board. I mean, what I've seen so far that's improved some stuff is bot technology, right? Especially in revenue side, taking away some of the simple repetitive tasks, hasn't reached the clinical level yet.
Right.
But I think it's coming, and I think it's going to have to be, combined with AI technology. But I definitely think it's on the way, and I love, Eric Topol's thought about it. I'm still a little skeptical because I don't feel like I have any more time these days. It's very stressful working, both me and my hospitalist team that I work with as well. They are carrying more patients than they ever have. The patients are sicker than they've ever been, and they're more stressed than they have been in the past from a time standpoint, and it decreases, our ability to spend time at the bedside. My favorite thing to do, and I do it with every patient, is I sit, right? Even if it's only for 2 minutes. But I'd love to sit go back and be able to sit for 5 or 10 minutes and find out a little bit about the patient, And I remember I was taking care of a guy yesterday, and I made sure I sit. I pull up a chair and I sit. And all he wanted to talk about, he didn't want to talk about his congestive heart failure or his, abdominal aortic aneurysm or any of the bad things that were going on with him. He wanted to talk about the Georgia-Florida game. And was he going to be able to have a beer if he was in the hospital? I assured him that he probably couldn't have a beer if he was in the hospital, but he could definitely watch the game. So he was positive and negative about the whole thing, but that was all he cared about. His family was in the room and they were overly concerned about everything else. And so I sat down and answered all their questions, but all he really cared about was, man, am I going to get to watch that Florida-Georgia game? That's all I care about. Can I drink a beer while I'm in the hospital? So I think being able to take that time, and I think earlier we talked about that I have my times when I struggle, right? And that I get just so far away from the purpose of what I do, that Simon Sinek purpose, and as the center of my target, that I really force myself to walk slower, think slower, and go in a patient's room, close the door, pull the curtain, and pull up a chair, right? And really make sure I do that, because that's part of what I love to do, right? I mean, I want to listen to the heart. I want to hear a cool murmur. I want to find a crazy sort of esoteric disease. I want to find that zebra and be the guy that found the zebra, right? But I also, want to be able to hold that patient's hand and chat with them. I mean, how often do I get to interact with 94-year-olds that aren't demented, and really get to find out what it was like 80 years ago, what life was like. And so, I cherish those moments, and I think we forget those. So if AI can give me some of that, right, I would love it.
All right. You mentioned finding a zebra. And for folks who don't know, we may have to have you explain that point. But one of the themes of horses versus zebras, we'll go a little bit lighter. And I think you took us there to wind up our time together.
Sure.
One of my favorite shows that I know for many medical folks is not their favorite shows is House, who's all about the zebras.
Yes.
A, can you explain to people the horse zebra thing? And B, what's your favorite of all the many, many, many medical shows over the years?
Okay. Yeah. So a zebra, so we see a lot of horses in our country. As long as we're not like in East Africa or South Africa, most of what we see are horses. It's the typical cough, cold, congestion. It turns out to be bronchitis or the flu, and everything's fairly typical and everything's fairly normal and everything's fairly standard. A zebra is something that is unusual. It was unexpected. It tried to sneak in behind the horse and get by you without you making the diagnosis. For example, somebody comes in with chest pain, and it really turns out to be a tear in their aorta and not a heart attack, right? Somebody comes in with a cough, and it's TB and not bronchitis. Somebody comes in with a headache, and it's a bleed, not just a regular headache. It's those things where you're constantly on the lookout for the zebra. And making sure you don't miss that zebra is always very, not so much satisfying. I guess it is satisfying in one way, but I hate to think of it that way. You've done a good job when you haven't let that slide by. but you shouldn't feel bad if it gets by you because they're sometimes hard and sometimes you'll miss them. I do believe that technology may help with that, right? That AI and some other technologies may help us to think about that in our differential diagnosis. I think it's important to stop and think and make sure that you don't miss anything. What was the name of the show? I always liked ER, but there was a show. It was called St. Elmo's Fire. What was that hospital that was associated with that show? I can't remember, Dave.
Yeah, I don't remember, but I know the show you're talking about. So that one was kind of your.
It was.
Your favorite?
I loved ER because I remember I was a resident and ER came out and we were all watching it going, oh, that's a bunch of hokey. He didn't do that. There's no way he was able to do that. The surgery guy was like, oh yeah, I know that guy. But I remember thinking, man, we should call Nike and have Nike do a commercial with us wearing Nikes in the ER, And so we could be like an ER Nike commercial because you're run around for 12 hours. But I guess ER would be one of my favorite shows back in the day when I was just coming up, starting. Because it was like, at least the first couple of years.
I had to end on that one on a little bit of lighter note because some of the stuff we've talked about is pretty serious. And ultimately, like I said, the horse versus zebra thing, and that was in the pilot episode of House, they talk about that. And that was one that my wife and I have watched and rewatched a couple times. But nobody, I feel like it's when I talk to, military, either current or former military, like they have a hard time watching military movies and shows, and most medical professionals I talk to have a hard time watching medical shows. But it obviously has a cultural fascination for us. And so that's where I hope that folks who are not in the healthcare universe have stuck with us here to the end today, maybe just out of cultural fascination. I'll try to close that loop and make this ending make sense. But I'm glad to have had you come on and speak with me today about the state of the ER, about technology, about why you went into this, about mental health, about all the many things we talked about today. But I really appreciate it and wish you the best in taking care of those patients out there every day that you're, putting on your scrubs and going to work. So Dr. Robert Wagner, thank you for being with me here on No Bad Questions.
My pleasure, David. Thanks so much for having me.